nice to eat. So, so welcome. So hopefully you've had some coffee as well. So I'm John Barrazzo. I head up the Maternal and Child Health Division in the Bureau for Global Health, USAID, where MCHIP has been housed these past 6 years. And we're pleased to also host the Maternal and Child Survival Program. We've got a great panel to talk about Scale Up. But first I really want to thank MCHIP and Koki and her whole team for all the support they've done putting this event together, but also for all the work that went into ensuring that everyone got where they needed to be when they needed to be there for yesterday's event. So these events, they astound me in terms of the number of details that have to be attended to, and you don't appreciate that if every detail is not attended to, things really get screwed up. So we're really glad that all these things didn't come off looking like school plays, but rather seem very professional and polished events. I want to make a shameless plug for a piece of work that Mary Ellen Stanton and her team put a lot of work into over the last few months. This is the USAID's Maternal Health Vision for Action. It has been released. It was an extremely quiet launch yesterday, okay? But it has been released. So this is actually fully aligned with the vision of ending preventable maternal mortality. It's worth a read. It's not even that long. Look at that. It's nice and compact. All right, so take a look at that. Yes, and a big round of applause. So this is the third of the topics for the day, and this is at scale. Scale obviously matters because scale matters to achieving public health impact. And we're going to be talking about questions like, what is scale? What is the impact we're trying to achieve? How do these issues relate to sustainability? How do we actually have a vision for starting at scale instead of a vision of just scaling up? And MCHIP has systematically examined these issues. You've got a systematic look at these issues in this report that's part of the folder that you received when you came today. So this is going to be one of the things we're talking about as part of the next hour and a half to 2 hour conversation. And we've got this conversation split into two parts. The first part, we're going to have several presentations by those who have been doing this stuff on the ground and also taking a look at the big picture and the overview. And the second, we've also got people who've been doing it on the ground, but we're actually going to be looking at it from more of a discussion rather than presentation. For both segments, I'm going to try to keep strictly to time and make sure that we actually have the chance to get some questions from the floor. We'll work hard to see that happen. So first, I'd like to introduce our panelists. Before I go to the panelists, I think I'd first like to, we have a special address from Dr. Diak from Senegal, who's the Secretary General of Health. He's a physician. He graduated from the University of Dakar, medical faculty. He holds an MPH. He started as a deputy health district team leader, became a district medical officer, was coordinator of the National Malaria Control Program, was responsible for preparing the first technical proposal submitted for financing to the Global Fund. And early in 2013, he was appointed Director General of Health. So he is going to be speaking, as I understood it, through a translator. So I'd like to invite Dr. Diak to come to the podium, make a few remarks, and then we'll actually proceed with our panel discussion.
Voilà. Merci, Monsieur Barroso. Mesdames et messieurs, bonjour. Je voudrais aussi vous souhaiter une bonne digestion et vous dire que je me réjouis de pouvoir faire une communication en ce qui concerne la mise en œuvre des interventions relatives à la santé de la mère et de l'enfant au Sénégal. Nous allons changer de style. Je voudrais, s'il vous plaît, faire ma présentation donc en français et nous allons avoir au fur et à mesure une traduction.
Thank you, Mr. Ngozi. Hello. I would like to first of all wish you good digestion and say how pleased Senegal is to participate in this important meeting on neonatal, maternal, and child health. And we're going to change styles a little bit here. I'm going to give my speech in French and speak through a translator.
Mesdames, Messieurs les administrateurs de l'USAID, Madame le directeur de MCHIP, Mesdames, Messieurs les ministres de la Santé, Mesdames, Messieurs les chefs de délégation, Mesdames et Messieurs les partenaires techniques et financiers, je vous cite l'USAID, l'UNICEF, l'UNFPA, la Fondation Bill et Melinda Gates, entre autres. Mesdames et Messieurs, honorables invités en vos titres et rangs.
Esteemed USAID administrators, Madam Director of MCHIP, Ministers of Health, heads of country delegations, technical and financial partners, and I would like to cite USAID, UNICEF, UNFPA, or UNFPA, and BMG, honorable guests, ladies and gentlemen.
C'est avec un réel plaisir que le Sénégal participe à cette importante réunion sur la santé maternelle, néonatale et infantile. Madame le ministre de la Santé et de l'Action sociale du Sénégal elle-même était venue en 2012 pour représenter le Sénégal au cours de cette première réunion, ici même à Washington. Ceci pour montrer toute l'importance que le gouvernement du Sénégal accorde à la réduction de la mortalité maternelle et infantile.
It is, again, with real pleasure that Senegal is participating in this important meeting on neonatal, maternal, and child health. The minister herself, the Minister of Health and Social Welfare of Senegal in 2012, was the representative of Senegal during the first meeting during that year here in Washington. This is to show the importance, the high level of importance that the government of Senegal attributes to the reduction of maternal and child mortality.
L'un des objectifs majeurs de notre plan national de développement sanitaire 2009-2018 concerne l'atteinte des OMD 4 et 5. Les indicateurs relatifs à la santé maternelle, néonatale et infantile restent élevés, mais il faut noter une tendance à la baisse, surtout en ce qui concerne d'abord la mortalité néonatale qui a subi une légère réduction, passant de 35 à 29, puis à 26 pour 100 000 naissances, pour du moins 1000 naissances vivantes, avec l'EDS 2013. Et il en est de même pour la mortalité maternelle, qui est passée de 401 en 2005 à 392 décès pour 100 000 naissances vivantes, avec les résultats de l'EDS de 2010.
One of the main objectives of the National Health Plan for 2009 to 2018 is the achievement of MDGs 4 and 5. The indicators for maternal, neonatal, and child health remain high. However, neonatal mortality has decreased slightly from 35 to 29, then to 26 per 100,000 live births with the 2013 EDS. And maternal mortality went from 401 in 2005 to 392 deaths per 100,000 live births with the 2010 EDS.
Mesdames et messieurs, permettez-moi de souligner la réduction drastique de la mortalité infantile qui est passée de 121 pour 1000 en 2005 à 72 pour 1000 en 2010, puis à 65 pour 1000 en 2013, eu égard aux enquêtes démographiques sanitaires réalisées.
Ladies and gentlemen, I would like to point out that infant mortality has seen a drastic drop from 101 in 1,000 to 2000 in 2005 to 72 in 1,000 in 2010, and then to 65 in 1,000 for the 2013 Democratic Health Survey that was carried out.
Pour atteindre cette performance, le Sénégal a adhéré aux initiatives internationales pour accélérer l'atteinte des OMD 4 et 5, mais aussi notre pays a eu à mettre en œuvre des interventions à haut impact, compte tenu des principales causes de décès constatées chez les enfants.
To achieve this performance, Senegal adhered to international initiatives to accelerate the achievement of MDGs 4 and 5, but our country has had to implement high-impact interventions on the major causes of death among children.
Après la réunion de Ouagadougou de 2010 qui a réuni les ministres de 9 pays de l'Afrique de l'Ouest sur le thème repositionnement de la planification familiale, l'urgence d'agir, le Sénégal a développé un plan d'action, d'accélération du moins, pour la planification familiale avec un objectif de taux de prévalence contraceptive de 27% en 2015. Ainsi, les efforts déployés dans l'offre de services, la demande, pour parler de la communication et du plaidoyer, et de la disponibilité des produits, ont permis de faire un bond remarquable de 4%, passant de 12% en 2010 à 16% en 2013.
After the meeting in Ouagadougou in 2010 that brought together 9 West African countries on the theme Repositioning Family Planning, the Urgent Need for Action, Senegal developed a national plan to accelerate family planning that aims to reach a contraceptive prevalence rate of 27% in 2015. So the efforts made in providing services and making products available resulted in a leap of 4 percentage points from 12% in 2010 to 16% between 2010 and 2013.
En réponse à l'appel à l'action pour la promesse renouvelée pour la survie de l'enfant, lancé à Washington en juin 2012, et l'initiative Life Saving Communities en octobre 2012, le Sénégal a élaboré puis mis en œuvre un plan d'accélération des interventions pour la survie de l'enfant et un plan de sécurisation des produits d'importance vitale pour la santé de la mère et de l'enfant, avec comme pour objectif de sauver au moins 10 000 vies entre 2013 et 2015.
In response to the call to action for the promised renewed for child survival, launched in Washington in June 2012, and Life Saving Commodities Initiative in October 2012, Senegal has developed and is currently implementing a plan to accelerate interventions for child survival and accelerating as well the availability of life-saving products for mothers and children. The main goal is to save at least 10,000 lives between 2013 and 2015.
Comme vous le savez, à travers une revue des différents plans existants sur la santé maternelle, néonatale et de l'enfant et une analyse situationnelle avec l'outil LIST, nous notons que les interventions prioritaires à haut impact peuvent réduire les décès des mères et des enfants en tenant compte des principales causes. Il s'agit notamment de la prématurité, de l'asphyxie, des infections chez les nouveau-nés, la pneumonie, la diarrhée et le paludisme chez l'enfant.
As you know, through a review of the various plans on maternal, newborn, and child health, and a situational analysis using the LIST tool, we have noted that high-impact priority interventions can reduce the major causes of death in mothers and children. These include prematurity, asphyxia, and infections for newborns, and pneumonia, diarrhea, and malaria for children.
Considérant ces éléments, des actions prioritaires ont été identifiées et développées dans notre pays. Et parmi celles-ci, nous pouvons citer, à titre d'exemple, l'extension des soins maternels avec la méthode kangourou pour la prise en charge des faibles poids de naissance et les soins essentiels avec l'approche Helping Baby Breast.
In view of these facts, priority actions have been identified and are being developed in our country. They include the extension of kangaroo maternal care for low birth weight babies and essential care with the Helping Baby Breast approach.
Le renforcement du programme élargi de vaccination avec l'introduction du vaccin antipneumocoque et du vaccin contre la rougeole et rubéole, mais aussi celui très prochainement du rotavirus, en plus des 9 vaccins du PEV de routine, portant ainsi à 12 les maladies cibles du PEV, que sont la tuberculose, la poliomyélite, la diphtérie, le tétanos, la coqueluche, l'hépatite B, les infections à Haemophilus influenzae B, les infections à pneumocoque, la rougeole, la rubéole, rotavirus et la fièvre jaune. Et l'enquête de couverture vaccinale réalisée en 2013 révèle que 70% des enfants sont complètement vaccinés, avec comme objectif donc l'atteinte de 80%.
Strengthening the EPI with the introduction of pneumococcus vaccine and the measles rubella vaccine, but also very soon rotavirus, in addition to the 9 routine EPI vaccines, bringing to 12 the EPI target diseases: tuberculosis, polio, diphtheria, tetanus, pertussis, hepatitis B, Haemophilus influenza infections type B, pneumococcal, measles, rubella, rotavirus, and yellow fever. The immunization coverage survey in 2013 revealed that 70% of children are fully immunized against a target of 80%.
Parmi les actions prioritaires, nous avons également le passage à l'échelle de la prise en charge des maladies de l'enfant, la diarrhée, les IRA, le paludisme et la malnutrition sévère, avec un fort accent mis donc sur le niveau communautaire.
Also among these efforts is the scaling up of childhood illness programs for diarrhea, ARI, malaria, and severe acute malnutrition with a strong focus on community work.
La disponibilité des médicaments étant cruciale dans ce dispositif, le Sénégal s'est engagé dans l'initiative de la Commission des Nations Unies sur les produits d'importance vitale pour la santé des enfants et des femmes. Et en effet, suite à la réunion du 14 au 17 octobre 2012 à Abuja, au Nigeria, le Sénégal a porté à 17 le nombre de produits sur la liste et un plan a été élaboré pour la période 2013-2015 et sa mise en œuvre est en cours sur le financement du Trust Fund et le financement également des partenaires, et cela au niveau national. Ce plan fait partie intégrante du plan d'accélération des interventions pour la survie de l'enfant.
The availability of medications is crucial in this approach. Senegal is committed to the initiative of the UN Commission for Life-Saving Products for Women and Children. Indeed, following the meeting of October 14 to 17, 2012 in Abuja, Nigeria, Senegal has increased to 17 the number of products on the list, and a plan was developed for the 2013-2015 period. Its implementation is underway with financing by the Trust Fund and national partners. This plan is an integral part of the plan to accelerate interventions for child survival.
Il est important de souligner que le gouvernement du Sénégal a initié une politique de couverture maladie universelle, prenant en compte la gratuité des soins pour les enfants de 0 à 5 ans, selon un paquet bien défini, mais aussi la gratuité de la césarienne pour les mères dans toutes les structures publiques. Et ceci vient renforcer, entre autres, les autres initiatives de gratuité, notamment la prise en charge du paludisme avec les ACT et les MILDA, la tuberculose et le VIH, pour parler donc du test de dépistage et des ARV. Et en plus de ça, l'organisation des communautés en mutuelle de santé qui seront subventionnées en partie par l'État permet également de renforcer ces initiatives de couverture maladie universelle.
It is important to note that the government of Senegal has initiated a policy of universal health coverage offering free care for children from 0 to 5 years and free C-sections for mothers in all public facilities. This complements the management of other free services such as care for malaria, ACTs and LLINs, tuberculosis and HIV, to include ARV and HIV tests. The organization of communities into health insurance programs will be partially subsidized by the government and will strengthen the demand for and access to care.
Mesdames et messieurs, malgré tous ces efforts, je ne voudrais pas terminer sans souligner les goulots d'étranglement auxquels nous sommes confrontés et les défis qui nous interpellent.
Ladies and gentlemen, despite all of these efforts and accomplishments, I would not like to conclude without mentioning the bottlenecks and challenges that remain. The most important of these are:
il s'agit de l'insuffisance des ressources humaines qualifiées et leur répartition dans le pays. Les zones avec des indicateurs en rouge sont les moins pourvues. La vétusté et l'insuffisance des équipements dans les structures, je parle des équipements de soins entre autres, mais aussi des moyens logistiques roulants pour les stratégies avancées dans les zones éloignées. L'accessibilité géographique des points de prestation de services dans certaines zones, la disponibilité des produits dans des points de prestation de services malgré les politiques de gratuité, le système de référence et de contre-référence qui aurait pu être amélioré pour une meilleure prise en charge des urgences et la persistance des pesanteurs socio-culturelles défavorables à la santé des femmes et des enfants.
Lack of skilled human resources and their distribution throughout the country. Areas with indicators in red have the poorest coverage. The lack of equipment in facilities, but also mobile logistic equipment such as vehicles for outreach activities in remote areas. Geographic accessibility of facilities in some areas. The availability of products at facilities despite the provision of free services, and an effective referral and counter-referral system for the management of emergencies. Also, the persistence of adverse health, social and cultural constraints for women and children.
Cependant, nous restons optimistes, eu égard aux opportunités qui s'offrent à nous, notamment l'adhésion du Sénégal aux initiatives globales concernant la santé de la mère et de l'enfant, le développement de la couverture de maladie universelle, l'engagement des partenaires techniques et financiers auprès du ministère en s'alignant sur les objectifs de notre plan national de développement sanitaire, la mise en œuvre d'un cadre de concertation avec les partenaires techniques et financiers s'activant dans la santé de la mère et de l'enfant à travers une plateforme pour la mobilisation des ressources supplémentaires et une meilleure efficacité de l'aide.
However, we remain optimistic given the opportunities that we have. Senegal's participation in global initiatives for RMNCH, EWEC, APR, A Commodities, Muskoka, Family Planning 2020, Decades of Vaccines, SUN, etc., the development of universal health coverage, engagement of technical and financial partners who are aligning their objectives with the National Health Development Plan for 2009 to 2018, the establishment of a harmonization framework with donors that are active in the areas of maternal, newborn, and child health through the RMNCH platform for mobilizing additional resources and greater aid effectiveness.
Je voudrais pour finir ajouter à ces opportunités l'élaboration d'une politique de santé communautaire et l'élaboration d'un plan stratégique de santé communautaire pour des interventions cohérentes et coordonnées, et aussi les initiatives intégrées de la prise en charge des maladies de l'enfance.
I would like to add to that list of opportunities the development of a community health policy and strategic plan for community health for consistent and coordinated interventions, and integrated initiatives for the management of childhood illness.
Mesdames et messieurs, merci encore de l'opportunité donnée au Sénégal pour partager avec vous notre expérience dans cette auguste assemblée. Je vous remercie de votre bien aimable attention.
Ladies and gentlemen, thanks again for the opportunity given to Senegal to share this experience with this honorable assembly. Thank you for your kind attention.
Thank you very much. Thank you. So thank you. Thank you to the Director General for that really inspiring example of Senegal, which is very relevant to the theme of going to scale and taking key technical interventions and addressing key bottlenecks to seeing those interventions go to scale and have the impact that we've been able to see and actually measure in Senegal. So now I'm going to proceed to introduce our panel, but first things first, who won the Germany-US game? Somebody in this room knows the answer. Okay, Germany won. Okay. All right. And now we will introduce our panel. So we're going to talk about scale, and we've got some great people here to help us discuss scale and what the experience of MCHIP has been. We've got Ida Lowe, who's the MCHIP Chief of Party in Mali. Ida is here. Please, Ida, raise your hand. Say hello. This is the... And she'll be talking about scaling up ICCM. She was most recently the chief, as I said, Chief of Party for MCHIP in Mali, but she began her public health career as a midwife in her native Senegal. She's worked in over 20 African countries, and she's also worked for the Senegalese Ministry of Health, USAID, and various international implementing partners, including Africare, JPIGO, and Save the Children. Next will be Bulbul Sood, MCHIP India, who raised her hand without even being asked to. This is the JPIGO India Country Director, and she's going to be discussing the scaling up of postpartum family planning in India. She's been the Country Director in India since 2009, and she has strong technical expertise in reproductive health, and she's well known in the fields of family planning, maternal reproductive health, both in India and internationally. She has been successful in moving India's safe motherhood agenda forward by working collaboratively with the government of India, bilateral, multilateral donors, UN organizations, and international and national NGOs. So we're looking forward to that. I was going to say first finally, but it's no longer finally. We have got Robert Steinglass looking at this looking at immunization, or specifically new vaccine introduction from a global perspective. Robert is MCHIP's immunization team leader as well as immunization senior advisor for John Snow, Inc. He has led immunization projects for JSI since 1990. He's worked on many USAID funded projects, including ones that I've seen come and go over the years. He was actually one of the first technical people I met in an aid project when I joined AID in 1992. Robert began his career with the World Health Organization in the mid-1970s, working on smallpox eradication in Ethiopia and Yemen. And then he served for 10 years as the resident WHO technical advisor for EPI, the Expanded Program on Immunization. And then finally, since we've reorganized things a small bit, we have Jim Ricca, who is the learning advisor for MCHIP, and Jim has worked on MCHIP since its start in 2008, both here in DC as well as in Mozambique. He practiced as a family doctor in Washington, D.C., and was as a member of the faculty of the Georgetown University Department of Family Medicine. So we've got a wide variety of skill sets and experience, and we're going to start with the first presentation from Ida on scaling up ICCM in Mali. All right, thank you.
Good afternoon, ladies and gentlemen, chair ministers and high-level government representative. It is my pleasure today to introduce to you the presentation on scale-up essential community care services, denominated SEC in Mali. The government of Mali has introduced the SEC strategy in Mali to respond to bring basic health care to the hard-to-reach communities. And we know in Mali, hard-to-reach communities represent 50% of the population who live beyond the 5 kilometers radius of a health center. What we call the SEC package is Mali, is very much integrated, is the maternal, newborn, and child health, family planning health services delivered by a new cadre of community health workers. I will also refer to community health workers as ASC, Agents de Santé Communautaire. So who are the actors delivering this package? At the center of the package is the community health workers, or ISA, who is a new cadre of community health worker who is paid a monthly salary for the provision of its services. I must just say that it is essential for the SEC implementation to have the engagement of various actors from community level up to government level. And the first actor under the SEC is the ISA. The ISA is supported by Relais Communautaire, and the Relais Communautaire, is the community volunteer who is based in small villages surrounding what we call the ISA site, the site ISA. They are doing community mobilization, and they are referring also cases to ISA. Those two actors are being supported by community members, and mainly by village chiefs and women's groups who are very active in supporting them. The two actors also, community actors, are being supervised and trained by the DTC. And the DTC is the health center's nurse, to which community health workers and relais are affiliated. This structure, like the health center and the community health workers and volunteer health workers, are all managed by the community association of health association called ASACO. And the ASACO is managing recruitment, relay recruitment, payment, and availability of resources at the health center. All this structure is now being supervised by the CSRF, called the district health centers, who are the Ministry of Health the structure representing operationally the Ministry of Health. And the Ministry of Health, of course, is the, in charge of policy definition and implementation and resource mobilization. It's very interesting to see the road to scale in Mali. From my perspective, it's been a very speedy startup and scale up, and I'm going to tell you why. Mali started to develop the strategy in 2009 to respond to the high mortality rate of children under 5. The strategy was implemented, the strategy was validated in 2010 after a very participative process involving civil society organization and partners. And the strategy began its implementation in 2011 with 580 ISA sites. And of course, what I'm calling a speedy process, despite the instability of in Mali between the 2011 and 2012, there was an instability in Mali. We all know that. But despite of the instability, and given the engagement of various stakeholders, the number of ISA sites quadrupled in 2 years. 2013 was marked by comprehensive studies who allow to determine the effectiveness of the first implementation phase. And results from these studies were used to develop what we call a strategy, a national strategic plan. The current geographic coverage of SEC in Mali is restricted to the 5 southern region, where 90% of the population lives. However, the SEC strategic plan is, has included expansion to the north in 2 regions out of the 3 regions of the north, and also into the suburbs of Bamako, where very important proportion of in-desert population is living, actually. The National Strategic Plan also is planning to double the number of actual SEC sites. As you may see in yellow in this slide, including because the actual SEC sites are in the southern regions, and the expansion will cover the Bamako district, Tombouctou, and Gao, and nearly bringing the ISA sites to 5,000 in 5 years. The SEC strategy scale-up is aligned with the MCHIP approach to effective and sustainable scale-up. Here we all know that scaling up strategy will require that all part of the engines work together under the HIS system to make it happen. In Mali, the most, they are working. In Mali, governance has been one of the main factors that facilitated the implementation of the strategy, and also its implementation to scale in a very quick space of time, in a very rapid space of time. The reason is the strategy began very quickly, and also an implementation guide was available. A coordination mechanism was put in place, and the implementation guide was made available to district-level implementers. And we know that since it has been integrated into the district operational plan, so it has benefited from the other elements of the health system strengthening. One of the challenge in the implementation and scale-up and sustainable strategy is of the scale-up would be the funding. The funding, because up to now, ISA salaries have been supported by donors' assistance. However, the government has planned under the development of the national strategic plan to include ISA salaries, and the plan has been already costed. The plan has been developed as a draft, and discussions are underway for its examination and validation.
Time's running out.
An essential part of the sex scale-up was the studies that have been developed during this year. General evaluation and other studies have shown results to evaluate effectiveness of the first implementation plan, have shown results that are being used for the development of the strategic plan. What have we learned so far? We have learned that there are 3 community health workers for 1,000 population under 5. We have learned that recruitment and retention of female community workers is essential. We have learned also that we need to improve the performance of male community health workers. We also need to develop ownership of data sets and for their supervision responsibilities. We also learned from another study, that there is an underutilization of sex services due to the beginning, and it is explained by financial barriers, due to the beginning of how the prices were set up. The prices were high, and that's why mothers, a few mothers were utilizing community health services of community health workers. Actually, during the dissemination of the study, local community association, the local federation of community association made the decision to lower the prices and to increase the access to those services. We have also learned that there is an enthusiasm and engagement and acceptance of SEC from the local communities. However, the ISAs are happier in communities where there was a good preparation of their installation. In regions where community mobilization and preparation has been made properly, ISAs are more supported than in other regions where these activities has not been conducted. We also learned that communities are claiming for more, are demanding for more services because of the fact that they really appreciate the services of community health workers. One mother who brought her sick child at the ISA site was very satisfied for the treatment she got. The child has malaria, but she left saying, his brother is 11 years old and I can't bring him here. So it brings a lot of confusion in the mind of the communities, why the ISA would be allowed to provide services to young children and not to their brothers or sisters. Our next steps will be to extend unreached areas in southern regions, but also to adapt the scale-up strategy and implementation process in the northern regions. There is also a need of improving capacity for analyzing and utilizing data for decision-making at the regional and district level through health fora. It's been productive. There is a need to maintain local government support, like the communes, CSOs, and also the private sector. We thank very much the Ministry of Health of the government of Mali, who has taken the leadership of implementing SEC to respond to high mortality rates, and also making the decision for Scale Up. We thank USAID for its constant support to support this activity, among others. We also thank MCHIP headquarters for their constant support, and Save the Children, who's been implementing MCHIP in Mali, and all other partners. Thank you very much for your time.
Okay, thank you. Okay, well, thank you very much, Ida. We'll look forward to the discussion. Now, there's obviously a lot of good issues there, rich issues about the complexity of who's involved and the complexity of some of the systems issues, and also the importance of evaluation. So let's now turn to Bulbul, her topic is already up there, scaling up postpartum family planning in India. So please.
Thank you, John. I would like to, in fact, say that I'm representing 1.2 billion people. And I would like to wish everyone here a very, a good day from them. If we look at, India is going to be #1 by 2030, and the estimation is that we would have 1.48 million by 2030. Lot has happened in India, and there are almost 21 states where we have reached the replacement level of 2.1 TFR, but still there is a high unmet need, and especially the unmet need is much higher in the postpartum period. And as the data shows that almost 70% of women in first 3 months are looking for, there's an unmet need for both spacing as well as permanent method. And this is reflected in the birth-to-birth interval in my country, where almost 60% of children are born before the 36 month of interval. But a lot has happened also in India in last, I would say, since 2005. We see that the institutional deliveries have really gone up, and almost half of the 26 million children are today born in institution because of the JSY, a conditional cash transfer scheme of Government of India. Around 2010, another change which was happening was that Government of India started talking about family planning as MNH initiative, and they were also started saying we need spacing. And I think this was an opportunity which was utilized to strengthen postpartum family planning, and MCHIP came in, and we worked very closely with the Government of India to not just strengthen the postpartum family planning, but also introduce IUCD in the postpartum period, because there was global evidence which was showing that IUCD can be given within 48 hours after delivery. I'll just share with you how we have expanded this program in the country. In 2009-10, we started with a couple of district hospitals and 1 medical college in Uttar Pradesh, the most populous. You heard from Gunjan. There are only 5 countries which have more population than Uttar Pradesh. And very soon, the results were very encouraging, and government said, let's expand it in another 20 states, and in 1 medical college and 1 district hospital. And from there, today, we have expanded it in the entire country. However, the technical assistance which we were providing to the Government of India is now focused on the 6 high focus states of the country, which has almost half of the India's population. And right now, all the district hospitals in these states are covered, and now we are also moved down to the sub-district level. Let me remind you, in India, the district covers about 2 to 3 million population. There has been rapid expansion of the services, and starting with 3 USAID supported MCHIP states, now it is all over the country. We have had more than 350,000 IUCD inserted during this period, and there are several sites which are now providing the training in the country. Almost more than 4,000 doctors and nurses have been trained, and services are provided through currently almost 550 service delivery points. If we look at the experience of the PPICD in the country, you can see there is a good mix of post-placental, which is within 10 minutes, in the cesarean period, trans-cesarean, and postpartum, which is within 48 hours. And this brings out the fact that the women are being counseled well during antenatal period, because within 10 minutes, you normally advise that the women should be advised about this method in the antenatal period. If we look at the numbers since in 2010, as you can see, we have been, annual increase has been substantial. And of course, the number of sites have also been going up, but the estimate is that, looking at the data till May of this year, in 2014, we may have almost 250,000 of IUCD. That means 250,000 women would have access to this method. If also looking at the proportion of the PPICD acceptors among the institutional deliveries, we see a very healthy trend. We started with about 4 to 5%, but now almost 17% of women who have institutional deliveries are opting for this method, and in some sites, almost 1 in 4 women are opting for this method, which is a good. I'd also like to reiterate here that I'm talking about PPIUCD, but all other methods have also gone up in the these sites, and because the counseling is done on all methods, and postpartum sterilization or even interval IUCDs have been shown a tremendous increase. If you look at the strategies, I think it was basically a system-based approach which was used from the very beginning, and I think that is the reason why we can see, how successfully it has been taken up. It was implemented through the system. There was no vertical system which was created, and using the NRHM, which is the Government of India's fund. This was definitely, as I said, a very strong policy shift, and government made clearly that this is now going to be an MNH initiative, and that we have to space. There was also the whole strategy was contextualized. The task shifting was an important lesson which was implemented. Started with the doctors, but gradually realized that unless you train the nurses, you're not going to achieve the results. There was all the standard operating procedures were developed. It was decentralized institutional training was, and now in fact we are going on to having on-site, whole site training. And then of course advocacy. And I think that success of this program has been because it has been led by the government from the very beginning. The participation has been there, the technical assistance has been provided, but it was always a government-led initiative. If you look at the sustainability of the program beyond external TA, and we heard in the morning what happens after external TA, as you can see, sites have shown increase in the IUCD acceptors. So this is in all the other states where external TA is not there. There was a strong buy-in by all stakeholders, and this is another good example where we started with most of the funds coming from the donor, but by 2012-13, you can see the donor money had almost tripled, and also it was the Government of India which was putting more than 50% of the money through the NRHM funds. We never thought, we're going to invest in quality later on. Quality was I think the hallmark of this program, where it was talking about postpartum family planning, competency-based training, clinical standards, counseling, follow-up, and everything. And I think that is what has resulted that even when the program moved and it was expanded so rapidly, we find that the annual expulsion rate has remained very low. I think one of the key success of this program. And of course, a very strong monitoring and evaluation system has been created. Again, it is within the health system structure, not a vertical system, with collecting the data, analyzing the data, giving a constructive feedback to the system, to the providers, bringing out new innovative things. In fact, it has been included in the HMIS. In the HMIS, we had just IUCD. Now it is separate. IUCD and PPIUCD and dashboard key indicators have been developed, especially looking at the quality. And of course, general evidence has been created, and we are modifying the strategies based on that. However, as we move on, the government of India also realizes that they would have to address continuously issues around quality of the services, informed choices, and follow-up. And I think since I'm more than optimistic that since the systems are there, since it is been taken care of from the very beginning, we would be able to take care of all these things. At the end, I would like to acknowledge, especially the Government of India, Ministry of Health and Family Welfare, at both the national level and at the state level, all the states that we work. And as I said, we work in all 35 states and union territory of the country. I would also like to thank the colleagues from USAID and also colleagues from MCHIP, both from my country as well as from the headquarters, the Bill and Melinda Gates Foundation, NIPI, Packard, the FOXI, and last but not least, the healthcare providers and the clients. Thank you very much.
Well, thank you very much. And certainly, always when we talk about India, the scale is always incredible. And to think about the scale of both the small efforts, but the scale of the scale-up required is also extraordinary. And also some very good, talking a lot about the issue of the importance of quality and also measurement and key indicators. So that's will provide some rich food for thought and discussion as we get into the discussion period. Next, I'd like to call up Robert Steinglass, who's going to be talking, now looking at a little bit from the global view at some of the challenges of scale-up of new vaccine introduction. Thanks. Oh, I should also compliment Bilbu. She took exactly 10 minutes. There's a clock here, and she was exactly on time.
Thank you.
That was deliberately for you, Robert, isn't it?
Obviously presents huge challenges, but I want to remind you that 130 million children are born every year, and each one of them needs to be immunized multiple times in the first year of life. That's another different kind of scale. So on behalf of the entire MCHIP field team and HQ team, and acknowledging, of course, the actions of all of the ministries of health with which we work, I'm going to be presenting about our MCHIP experience on scaling up new vaccine introduction. Let me just go back for a second. Achieving scale with vaccines, not just new vaccines, but old vaccines as well, is essential if we want to reap their benefit. The aim of immunization programs is not only to immunize or to protect the individual, it's also to protect the entire community, the entire country, by reducing overall transmission of disease through herd immunity, and also by shrinking the reservoir of infection. So a little history is helpful. Immunization programs are designed from the start to achieve high coverage at scale. As I said, every year 130 million kids are born and they need to be vaccinated. As you can see from this slide, immunization coverage increased rapidly from the 1980s in each of WHO's 6 regions. Those are shown in the colored lines. The global annual coverage is shown in the orange or yellow bars. Success was declared in 1990 when the global immunization target of 80% was reached, even though, by the way, 107 countries never actually reached that global target. But coverage, watch what happened in 1990. Coverage dropped dramatically in the 3 weaker regions, Africa, Southeast Asia, and the Eastern Mediterranean, as shown by the lower 3 lines. And this drop was because external resources were suddenly withdrawn. Countries had become dependent upon these resources. They were suddenly withdrawn, and the mass campaigns that had been used artificially to boost coverage to rapidly achieve those 1990 targets came to an end. So the lesson was that it was clearly easier to achieve scale than it was to sustain scale in the weaker regions. To achieve scale, we also need to address inequity within regions, within countries as well. And these survey findings from Africa illustrate the equity gap in coverage between the lowest wealth quintile, which is the darker color, and the highest wealth quintile, which is the lighter color for each of these countries. Just take a look at Nigeria, for example, where only 8% of the lowest wealth quintile is covered versus 76% of the highest wealth quintile. The pace of new vaccine introduction has been accelerating since the early 1990s and is due to continue to increase. The good news is that the investments of the past in developing routine immunization systems are starting to pay off now in that because those relatively mature programs exist, it means that it's relatively easy to execute relatively easy to introduce new vaccines into a well-functioning system. So what do we do at MCHIP? This shows across 6 different vaccines. We provided technical support to build country capacity, to submit their Gavi applications, to prepare introduction plans, to do the launch, to do post-introduction monitoring, and to do post-introduction evaluation. Now, I don't expect anybody to read this unless your eyes are a lot better than my eyes. I can't read it even from here. But this detailed scale-up map shows that there are a lot of steps that need to be implemented throughout the process of introducing a new vaccine. And what we did at MCHIP is we customized our technical support to help across all of these steps. Even as in yellow, what really attracts most attention is the launch, which is a big, high-visible political event. But look at all the steps that have to take place beforehand to make sure that introduction is done smoothly. We also focused on routine immunization system strengthening, since the effectiveness of introducing a new vaccine depends upon a strong routine immunization program. Because a new vaccine immediately becomes part of the routine program after the launch, in other words, it becomes an old vaccine, partners have an opportunity but also an obligation to direct all of this high visibility focus from new vaccine introduction to also strengthen the routine immunization program. USAID has bought $1.2 billion of USAID has bought $1.2 billion of vaccines through Gavi, $1.2 billion. MCHIP, through its technical support to countries, complements that investment. We help reap the benefit of those vaccines, and we protect USAID and other partners and ministries of health's own investments in vaccines, because the vaccines simply don't deliver themselves. You need a program, more than vaccines, to vaccinate the population. So this slide shows the results of lives saved by MCHIP's end, and by the time that these specific new vaccines reach peak mortality impact in the year 2020. So our actions with ministries of health will have supported countries to save hundreds of thousands of lives. These figures are based on the specific new vaccines that were introduced at the time of the analysis, but there are hundreds of thousands of additional lives that will be saved as all of these countries continue to introduce all of these vaccines. And just think how many more lives could be saved if all countries were effectively to introduce all of the vaccines. But these lives are only going to be saved if routine immunization programs remain strong to deliver those vaccines uniformly, year after year, at scale, and without sacrificing quality as one goes to scale. By design, the way USAID designed MCHIP, we also had a functionally aligned program at all levels. And here are just a few of the examples of some of the global policy and strategy setting panels that we served on, and on which we were able to bring our field learning to influence the global policy and strategies. and where we were able to explain what it actually takes to introduce a new vaccine. It's not done overnight. It requires a lot of methodical care and what it takes to keep the routine immunization program strong. Now, new vaccine introduction also requires not only the detailed planning and the quality of the preparations, but the underlying strength of the routine program, as I said. And this is what we found when we did a review for WHO of the effect that new vaccine introduction has on routine immunization systems and on health systems. So we found also that to have a positive outcome on new vaccine introduction and on the underlying routine immunization system, that we needed to support the ministries of health beforehand to identify what were the particular system challenges so that through good planning, the introduction of the new vaccines could be used deliberately to also address those weaknesses with sustainable remedies. We learned also that in the weaker countries, the routine immunization programs are very stressed by the introduction of new vaccines, and that if one doesn't deliberately take care to avoid them, negative impacts are as likely as positive impacts to be the result. The new vaccine introduction has exposed cracks in the immunization supply chain from 2010 to 2020. We expect a 4-fold increase in vaccine volume that needs to be stored, a 6-fold increase in doses, a 5-fold increase in vaccine costs, and a 2-fold increase in the amount of cold chain equipment that's needed. This is important because most of the global attention on new vaccine introduction is focused on the power of vaccines, on the supply of vaccines, the finance of vaccines, the development of vaccines. But there isn't correspondingly enough attention addressed to what are the non-vaccine systems costs that will also need to be addressed, as you can see in this slide. So at MCHIP, we feel that in order to succeed, we have to apply systems thinking. In order to build a program that is cohesive, and this applies not just to routine immunization, but probably to many of your programs as well. In order to have a cohesive, non-fragmented program and to sustain performance at scale, we need to attend to all of the pieces of the puzzle, each of these component parts. We have to think about building strong routine immunization systems as a development challenge, not only a successive series of disease control challenges. This requires customized strategic thinking and systematic thinking. Countries need more than just vaccine. They need a balanced and multidisciplinary package of technical support from partners across all of these components, and they don't get it. To build programs in weaker countries, sustained human and financial resources are needed, and they need to be directly invested in strengthening the routine immunization program in order to solve the deep-rooted problems. Because these require a longer-term focus. The strengthening of the system is not done as a byproduct of other interventions. It has to be addressed directly. So new vaccines, as I said, they've captured the imagination of policymakers and funding agencies. But let's remember to also invest in the routine immunization platform as well, because that platform is needed if we want to introduce the new vaccines, if we want to reach measles elimination goals, tetanus elimination, polio eradication, family planning, support other health interventions, if we want to offer immunizations across the entire life cycle and add other interventions. We need that strong routine immunization platform, without which none of our goals are achievable. So in conclusion, the relatively mature immunization system means that a well-executed new vaccine introduction can go to scale rapidly. The effectiveness of new vaccine introduction depends upon the strength of that routine system. As I said, once introduced, the vaccine becomes an old vaccine and they don't deliver themselves. So to have a positive outcome, you have to identify what those problems in the system are at the beginning to try to use new vaccine introduction as a vehicle to strengthen the underlying system. New vaccine introduction can be a system stressor, particularly in weaker countries, but it could also strengthen the system if it's done deliberately. Achieving scale could be easier than sustaining scale, as we saw from the historical example from the 1980s and 90s. You can't have effective scale without also addressing equity and quality. And quality is really important because sometimes quality is lost in the process of scaling up. And then technical support is needed if we're going to reap the benefits of these investments in vaccines. Technical support through all of the preparatory steps that I showed on the scale-up map. And as I said, MCHIP supported countries through all of those steps through a systems approach stressing sustainability and quality. So just to let you know that we've just released yesterday, in time for this meeting, our monograph on new vaccine introductions, bottlenecks and breakthroughs. It describes the lessons that we've learned on new vaccine introduction. We're going to be distributing that widely, and I'm sure it's available in the documentation for this event online. So thank you very much. I just want to remind everyone that we need to make sure that every child is a VIP. Vaccinated, not only vaccinated, immunized, not only immunized, also protected. Thank you.
Thank you, Robert. Well, thank you, Robert. A lot of food for thought there and some of the key themes on equity, sustainability. I've always liked Robert's delivery of the line, vaccines don't deliver themselves, and again, the importance of systems thinking. So now Jim is going to come up and he's going to talk about a way in which all this has been tied together conceptually and in terms of actually an evaluation, systematic evaluation of scale-up efforts. And I think this is going to be an opportunity, and then we'll have an opportunity hopefully for about 10 minutes of discussion after that. Thanks. Come on, Jim.
Thanks, John. And thanks to everybody here. I have really good news for everyone, and that's that this is the last PowerPoint of the day. So there you are. I also want to let you know that in our family, we really try to make sure that we walk the walk too, and so I've encouraged my daughter to think globally, and I'm not sure if it's more important that she's going to Nicaragua this summer for a service project or that she instant messaged me to let me know right away that the U.S. lost the soccer game. So I wanted to say that in terms of scale and why study scale, I think there was a really fantastic article in the New Yorker last fall that kind of should really get us thinking. If people didn't see it, you should look it up, by Atul Gawande, and who always writes provocative things. And he talked about why there was a difference, or why we might think there might be a difference in terms of scaling up. Two different things that were near and dear to his heart, and those are, as a surgeon, one was anesthesia and the other one was antiseptic technique. He said certainly antiseptic technique was easier to do, but it was less sexy, and it took an awful long time to scale that up versus anesthesia. And so anyway, you should take a look at that article. He also talks about midwives in India, so I thought that was quite an interesting tie-in. Well, in any case, impact at scale. I think that was the first and foremost objective of this project, and so I want to kind of bring it back around to what we heard about at the beginning of the day from Koki. We've heard about impact at scale and different facets of it in the other panels, community in terms of getting the interventions to those that need them. Also quality and making sure that we really have effective coverage and not just coverage. That's certainly an important point. And then you've heard three different case studies. So I think we probably all know what we're talking about when we say scale or scale up, but I think it's also important just to lay it out and actually say what we're talking about. So here is a common definition that's used by ExpandNet, some folks who used to work at World Health Organization and thought about this quite a bit, and we use this definition under MCHIP. You can look at it here: deliberate efforts to increase the impact of health innovations, tested in pilot experimental projects, so as to benefit more people on a lasting basis. So part of it here is that we're benefiting more people, so we're increasing coverage, and part also that we are trying to make sure there is institutionalization and therefore sustainability. So both those things are important. Traditionally, we talk about pilots going to sustainable impact at scale and going through a series of stages. That's not really the way it happens in the real world, so to speak, anymore. I think we found at HBB, for instance, helping babies breathe was something that a lot of countries just wanted to scale up immediately. And that's true with a number of other interventions that we've seen. I think that makes it even more important that we think about the idea of impact at scale, and therefore that in order to have impact at scale, that we have to both be reaching the right people and making sure that we get quality. Because if there's going to be a lot of pressure to scale things up quickly, those things maybe can get left behind. So when we think about scale up, let's just first think about what we call the elements and strategies. So in other words, who is scaling up, what are they scaling up, and how are they doing it? So first of all, we have to really be clear among all partners in a country that's scaling something up about what exactly we're scaling up. Sometimes that might seem easy, but for instance, postpartum family planning, that's both the counseling and it's the technical pieces of making sure that providers are trained to do postpartum IUDs or other sorts of things that they need to know. The implementers, of course, the Ministry of Health is leading here. Civil society, though, can be involved. Other actors can be involved. What we call the resource team or the technical work groups, and these are people that are helping to advise the scale-up process. And they all work within an environment. What do we mean by the environment? Well, we mean the policy environment, the stability in the country, all these sort of things that are outside the control of people that are trying to do the scale up, but that are obviously going to impact what happens. And scale up strategies. There's several that are talked about very commonly. Dissemination and advocacy, doing a pilot, telling about the results of that, telling about a new WHO policy. Capacity building, obviously important. Resource mobilization. Misoprostol in 2 states of South Sudan from MCHIP, financing and technical assistance, now with technical assistance and financing from DFID, from World Health Organization, from others in other states. Monitoring and evaluation. Unfortunately, I think this is something that a lot of times we do evaluation and we don't necessarily have good data on a lot of scale-ups about what's happening monitoring-wise day to day, well, maybe not day to day, but certainly quarter to quarter and year to year. I think you've heard about some good examples, though, where people were trying to figure out how to get some data that they could use for management. And lastly, community engagement. I think this is something that's forgotten about sometimes. Again, just to remind us, we're trying to get both institutionalization and we're trying to get increased service coverage, and in that way, get sustainable impact at scale. So what did we try to do under MCHIP? We were trying to help countries, and you can see them here, the 10 interventions that MCHIP concentrated its effort on in terms of scale up. And these 6 in particular, we tried to study in more detail. And here are the places where we try to study them. We would have loved, of course, to have studied all those, but we wouldn't probably have enough resources to do that. So here are the places where we try to study postpartum hemorrhage prevention, especially adding misoprostol and not harming oxytocin use in facilities, helping babies breathe, integrated community case management, postpartum family planning, new vaccines, and malaria and pregnancy. Just want to give a little bit of, let me just go back actually and just say, first of all, I think it won't surprise anybody to know that we found out that new vaccines, in terms of service coverage, went the most quickly and were able to reach the most people most quickly. On the other hand, also, quite interestingly, I thought there were some very quick gains on some of these other interventions here, and in particular for malaria and pregnancy, although they didn't reach 80% targets in any of these 3 countries, they came quite close. And helping babies breathe has scaled up in a number of countries, is reaching a number of babies. I think now the question is, can that be done so that so that skills are maintained and we really do reach impact at scale? Some of the other ones like ICCM and postpartum family planning are on their way to scale up, and I think postpartum hemorrhage prevention through adding misoprostol is something that's at an earlier stage at this point, but still some very good groundwork has been laid. So one thing that's very striking is this, and I think again Atul Gawande comes to mind, is why is it that certain things are scaling faster than others? And he really put it in a behavior change kind of perspective. Certain things just fit with the things that we want to do. One thing that's in the scale-up literature a lot from a technical perspective is to say that it's really difficult to scale up a complicated intervention, and an easier intervention, something that's simpler, is something you're likely to be able to scale up more quickly. And yet, some interventions here are quite complicated, like ICCM, and yet they're on their way to scale up. So I think some other things about these interventions are more likely to make them be scaled, really fitting within country plans, really fitting within the priorities of the country are certainly as important as how complicated a technical intervention is. We also tried to take this idea of institutionalization and really be systematic about our look at it. And you can see here that if we count a 0 as not at all institutionalized and a 4 as being completely institutionalized, which is quite a high bar, every one of these interventions has moved along quite a bit. Some of them started out even at the beginning of MCHIP already with not at zeros, so to speak. I can talk to people later if you want to know how we got this data, but suffice it to say that we interviewed people in country, MCHIP teams, along with ministries of health and other implementers to try to get a consensus about this.
Jim, you better accelerate a little bit.
Yep. And so just to give a little clearer sense.
It's a real good reason to accelerate.
Yeah?
Yeah, you probably should hurry up. If you could hurry up a little bit.
Okay. Just to give a little clearer sense of what it is that we're talking about here, if we have the outer circle here as being fully scaled up and fully institutionalized, and we were trying to get a full circle here, you can see that HBB did quite well, starting at the blue and moving to the red. It moved along quite a bit. It didn't get a completely full circle. Some of the things it didn't, it still needs to work on our supervision, quality improvement, logistics systems. And you can see here again, new vaccines leading the way. So just a few final thoughts before I turn things over to the administrator. And that's, I would like just to emphasize a few things here. First, system thinking. I think you've heard about that before. I think it's really important. What that means is we're really not trying to scale up HBB. We're really not trying to scale up new vaccines. What we're trying to do is solve system bottlenecks. And you're only as good as the weakest link. So if you have well-trained providers, you have a supervisory system, but you don't have product, you don't have a program. And I think that's an important thing to keep in mind. I'll just leave it there and leave the rest of the things for later.
Thank you, Jim. Okay, thank you. We're very pleased and honored to have join us for a few minutes the administrator of AID, Dr. Raj Shah. And I know he cares a lot about the things we're talking about right now, scale, impact, and from personal experience, measuring lives saved. So welcome.
Thank you. Thank you, John. Thank you, Jim. I'm sorry, Jim, to kind of kick you off stage here. I was waiting to hear what it meant on that last slide. I just want to say thank you. I want to thank Koki Agarwal for her leadership, and Megan Rhodes and Katie Taylor, Elizabeth Fox, John, Ariel, our whole USAID team for your great efforts, especially working on this project in the past and importantly going forward. Nahed Mata as well for your leadership. You know, this has been an extraordinary partnership, obviously, that has gone on for some time. And I am excited that we're able to renew this partnership with this $500 million commitment over the next years. And it's important that this is, in fact, a partnership that's grounded in a shared aspiration, a clear understanding of what we're trying to do together, a desire to share our learnings with each other, which is why, Jim, I'm really, truly sorry that I kicked you off stage here, because you know that's what it's all about. It's sharing these really specific insights. And I do also think it's important that we work together to communicate what we're doing with our country partners and take their direction in how we go forward. So I had a chance to visit with a lot of our delegations that have come as part of yesterday's call to action. And the reality is the only reason we can now envision credibly the end of preventable maternal and child death, and the only reason we can stand here and with confidence suggest that our activities taken together in the next few years can save 500,000 child lives is because country after country, they're setting quantitative measurable targets and linking those targets to action plans that describe which specific interventions need to scale to which specific populations, district by district. I just spent time with my Bangladeshi colleagues, and they were describing the data system they use to collect information about scale-up of 17 priority interventions. That's the kind of approach, if taken rigorously across all districts and all high-risk populations in the places we work together, can deliver success and outcomes. So I just want to offer my congratulations to you. It's your efforts that make this a standout program. It's your efforts that will allow us to have the technical rigor to implement, this vision. And what I was telling Katie as we were walking down here is, I just love the fact you can open up a country, you can see the drivers of mortality and where expectations for mortality reductions come from. You can understand what the curve looks like if it's optimized against the target, and you can count the result. And that gives you a management platform to feed your expertise and your knowledge in, so you know that your time and your knowledge and your insights are being spent most effectively to deliver this extraordinary moral outcome of ending preventable maternal and child death. And this morning at our ministers' breakfast, they raised the suggestion that every year we should gather here and we should share our experiences with each other. And we should look and track our progress on following the roadmap we've created together. Because that kind of implementation rigor and that kind of commitment year after year is what's going to be required to deliver on the call to action. So I don't want to take up too much of your time because you're obviously sharing important technical insights with each other. But I do think we ought to commit ourselves to that kind of a process, and that Johns Hopkins University and the NGO partners and scientific experts all need to come together and make this a process. Together we can do this, but we got to hold ourselves to account, we got to assess our performance, and we have to be rigorous about actually implementing the plan we've now laid out. So thank you, and I wish you the best of luck for the rest of this meeting. Thank you very much.
Okay, great. Well, that timing was perfect, and I'm not sure where we're at on time. We are still planning the wrap-up remarks. If we have 5 minutes for questions, great. So we can open it up for some questions from this panel. First question, please. You have a mic roving here? Mm-hmm. And the translator is running towards you.
De nous avoir invités ici et tout ce qu'on fait ensemble dans nos pays, en particulier au Mali. Notre coopération avec l'USAID a beaucoup évolué ces derniers temps dans la bonne direction. Parce que pendant longtemps, c'était un partenaire isolé, mais je crois que maintenant, c'était un partenaire qui faisait des choses visibles, mais des choses à part. Maintenant, nous faisons tout ensemble et nous pensons que ce partenariat est très fructueux et la qualité s'est beaucoup améliorée. Nous n'avons... C'est vite?
First of all, I would like to thank all of those who came to this meeting to exchange ideas with us, for us to exchange ideas with each other. I would like to thank the USAID for hosting this meeting, for having invited us, and to thank the USAID also for all the work that we do together. Mali has been cooperating with the USAID, and this cooperation has evolved in the right direction lately. At one time, it seemed that USAID was taking many actions in our country, but in an isolated way, although visible. Now we are starting to do everything together, and that has become a very fruitful partnership for us.
Je voudrais remercier Edalo de MCHIP, la présentation qui a été faite sur MCHIP, la qualité de la présentation, et remercier notre collaboratrice Aïda qui a fait une bonne présentation du système de santé du Mali, ce que nous appelons la pyramide sanitaire. Je voudrais ajouter à cela que depuis 1998, le Mali a opté pour l'approche en termes de programmes intégrés. Il y avait plusieurs programmes verticaux qu'on a décidé de mettre ensemble, donc sous forme de paquets de services. Et j'ai remarqué à travers toutes les interventions que tout ce qui a été présenté ici, nous avons un échantillon de tout cela chez nous. Ça veut dire que nous avons, peut-être que le Mali a été très ambitieux de vouloir faire tout à la fois, mais en tout cas, je me suis reconnu dans presque tout ce qui a été exposé ici comme expérience. Et ce qui est... Oui.
I would like to thank MCHIP for the quality of the presentations that I've seen here, and thank our collaborator Aida, who presented Mali's programs in a very informative way. I would like to say that since '98, Mali has opted for an integrated program approach. We had many vertical programs which we decided to put together as service packages. And I can say that in all of the speeches and presentations I've heard today, or here, I have seen a sample of everything that we have done in Mali. So you could perhaps say that Mali has been very ambitious, but I recognized myself in many of the things that, in our programs, and many of the things that I have heard here.
Je ne vais pas tout rappeler, mais je vais m'appesantir sur la santé maternelle, néonatale et infantile, qui a été considéré comme un aspect essentiel de la politique de santé publique au Mali.
I am not going to list everything. I would like to just focus on maternal, neonatal, and infant health, which has been an essential program in Mali.
Il y a la couverture universelle dont il a été question. Je voudrais rappeler également que le Mali a opté pour un système de financement universel à deux caisses. Il y a une caisse qui est appelée assurance médicale obligatoire, où tous les salariés sont obligés de cotiser pour assurer la couverture des soins. Et il y a l'assistance médicale qui est l'autre caisse où il y a une subvention pour ceux qui n'ont pas les moyens.
I would like to say, first of all, that we have integrated universal coverage, which is divided into two categories, two ways of funding this coverage. First, there's required medical insurance where employees have to pay for insurance out of their salaries, have to pay fees. And then there's another branch of coverage, which is for those who don't have the means, and that is subsidized.
Je voudrais rappeler qu'en 2012, nous avons été confrontés à un conflit armé qui a perturbé l'évolution du système de santé, conflit armé sur fond de revendications indépendantistes, à la fois de revendications religieuses et d'influence de narcotrafiquants. Et donc, il y a eu un conflit armé qui a détruit tout le système au nord du pays. Les infrastructures de santé ont été détruites, mais grâce à la coopération avec nos partenaires, on a trouvé quand même le moyen de maintenir certains acquis, les acquis essentiels, et nous remercions tous les partenaires pour cette marque d'assistance à nos populations.
I would like to add that since 2012, as of 2012, we were faced with an armed conflict that greatly disturbed the evolution of our health system. This armed conflict was the result of various tendencies, religious tendencies,
tendencies for independent movements to develop, and also drug traffickers influencing this process. This armed conflict destroyed our health system in the north, destroyed the health infrastructure. But thanks to our partners, in cooperation with our partners, we were able to preserve certain assets, and I would like to thank our partners for that.
Je voudrais finir par rapport à ce qui a été présenté, à savoir la contribution de la communauté qui est une bonne réponse, qui peut être une bonne réponse à l'insuffisance du personnel et à l'instabilité du personnel, ce que nous appelons personnel conventionnel, parce que nous avons effectivement ce problème-là. Je voudrais rassurer ici que c'est une expérience que nous apprécions et je voudrais m'arrêter là parce qu'il y a beaucoup à dire. Je remercie de votre patience. Merci.
Okay, merci.
As regards what has been presented, I would like to focus on community contributions. I believe that to be a good response to problems of insufficiency of personnel or the instability of what one thinks of as conventional personnel. We've had this problem, and I would like to say that I think this is a good solution to this problem. I will stop here because there's a lot to say. I thank you for your patience. Thank you very much.
Okay. I think the unfortunate truth is that there's a lot more to say than we possibly have time to say in an afternoon. So I think that we're going to move now to the next panel, and I just hope, and we will reserve more time for discussion and questions after that. So if you've got some ideas, you want to put them on the floor, please do. And I would encourage you in the next, as we discuss things, please try to make your points very succinct because we're going to have a real time crunch now, trying to get to the end of the day. All right, thanks. So let's thank our first panel. And I'd like to invite the second panel to come up to the stage, please. That includes, well, excuse me, my own papers have gotten a little bit in disarray here. I'm sorry. So that would include Dr. Shahidullah, Berta Pooley, and Jeff Smith, please. In that order. And so we've heard a little bit already today that for the interventions around which we have strong technical consensus, and that technical consensus is we know what works, it's backed up by evidence, and that if we devote attention to the key systems issues and the bottlenecks required to actually roll those interventions, the bottlenecks we have to overcome to be able to roll those interventions out, that in fact this kind of systems thinking is critical to achieving scale with sustainability. And so we now have three panelists with whom we'll first have a moderated discussion. I'll be the moderator. And then we'll hopefully have some time for some questions from the floor before we actually wrap up for the day. We're still getting mic'd up, but meanwhile I will introduce the three of them as they are coming onto the stage. So our first panelist is Dr. Mohammed Shahidullah. Have I pronounced your last name correctly? Good, thank you. And he's now working as professor and chairman in the Department of Neonatology in a medical university whose name I cannot possibly pronounce correctly, but I'll go for it. Here we go. Bangabandhu Sheikh Mujib. Good, okay. Otherwise, BSMMU. And he also holds the position of immediate past president of the Bangladesh Neonatal Forum and a host of other professional societies in Bangladesh. He is working as the project director for the Scaling Up project for Helping Babies Breathe, the Helping Babies Breathe initiative in Bangladesh. Our second panelist is Berta Pooley. She is from the LAC Neonatal Alliance, and she's a sociologist. And this is what I love about the LAC region. In the LAC region, you find sociologists working in public health. This is the great thing. Sociologist working in health and development for over 20 years. She's served in Bolivia as the executive director of PROCOSI. Those of you who've been around for a while might remember PROCOSI and the establishment of that. It was a network of 24 NGOs. It is a network of 24 NGOs. and she has participated in numerous consultancies for a variety of organizations and really focuses on building capacity on issues related to advocacy and program design, development, and evaluation for women, newborn, and adolescent health and community empowerment. And then our third panelist is integral to what MCHIP's been working on and trying and achieving in maternal health for the past 6 years, and that's Jeff Smith. Jeff Smith is MCHIP's maternal health team leader, and he has a background that includes management of clinical service delivery and training for maternal and newborn health services. He has had a lot of international experience, extensive experience across many continents and countries, Asia, Latin America, and Africa. But for 3 years, he also served as Safe Motherhood Advisor and was subsequently country director for JPIGO programs in Afghanistan. So with that, we're going to turn to some questions for the panel. This is going to build on some of the things we heard in the PowerPoint presentations. And so I'm going to take my seat and we're going to have one of these facilitated discussions on stage. I'm going to try to emulate the style of Nazo, which is really going to be a challenge.
Just
Jeff, are you
yeah, I'm sorry.
with us? Or?
We're just going to get a piece of paper.
Ah, yes.
Oh, here.
Okay, so the first question. Representing variously national, regional, and global perspectives. So what was scaled up? Why was it important to scale it up? And who has been involved in the scale up? So, here.
Right, thanks John. First for the introduction of the Bangabandhu Sheikh Mujib Medical University where I work. And I'd like to thank the organizers, particularly USAID and MCHIP, for inviting me and giving me the opportunity to share the scaling up of helping babies breathe. To start with, you have a set of questions. One is what was being scaled up. One is HBB, which is popularly known as helping babies breathe. But before I talk about helping babies breathe, let me give you the context on what this was being built on. In Bangladesh, we have seen a significant progress in reducing under 5 and infant mortality in last several decades. But newborn mortality, which is declining but at a slower pace, and as of now, it accounts for about 60% of the under 5 mortality being contributed by newborn death, as opposed to the global figure of 44%. So therefore, and we have got 3 major killers in newborn period. One is birth asphyxia, the other one is infection, preterm, and low birth weight. Considering that scenario, the National Neonatal Health Strategy and Guideline, which was developed in May 2009, which highlighted that all 3 areas to be addressed. And about birth asphyxia means a baby who is born is supposed to cry. The baby is not crying, so baby is asphyxiated. That baby needs a help from the service provider, that is assisted ventilation, known as resuscitation. That was the time Bangladesh we have been looking forward to see a very effective intervention, how to tackle the situation. And American Academy of Pediatrics came forward with a very simple, innovative newborn resuscitation protocol, is HBB. And that was, that was efficacious, but then it needed whether this is feasible, that this skill can be transferred at all levels. And that was the reason that there was feasibility study. Bangladesh is one of those 5 countries who piloted this study, and that was supported by USAID and MCHIP. And when we did this study, we made a dissemination seminar where it was shown that the grassroots level health workers like SBAs, community SBAs, they could perform very well. They could demonstrate the bag and mask ventilation on a mannequin, which has been developed by, I think, Tor is here, the Ledel Foundation, they did it. And in the dissemination meeting, there was the presence of the minister, health secretary, other policymakers, development partners, academia, professionals. And all were overwhelmed when they saw that the community skilled birth attendants, they can perform the bag and mask and they can inflate the chest of the mannequin. And that the health minister instructed the directors, 2 directors we have got, one is Director General of Health Services, The other one is Director General of Family Planning, and instructed them, please do not limit this is as a finding of the feasibility study. Let us scale it up. And he instructed this should be done in 6-month time. He also requested the development partners, and the development partners, particularly I'd say USAID, MCHIP, UNICEF, and all others, they said they showed their commitment that they are going to support that. So there is a commitment from the government, there was a support from the development partners, and professional academia and other NGOs came forward. All clicked together, and actually we had HPB there.
Okay, great.
But then the second part of who is implementing it? It is the government. Government is playing the key role. Government is actually has taken into its policy. At the ministerial level, there is a commitment. There is also commitment in the at the level of the DGs, and also the government is utilizing its institutions like at the national level, this Bangabandhu Sheikh Mujib Medical University, medical colleges, district and sub-district institutions. They are being utilized as the venue of training and also service provision. And all the government machineries, that is the people working in the Director General of Health Service and Family Planning, the district managers, sub-district managers, they were very much involved in rolling it out, and also they were involved in arranging the training program, supervising the training program, and also helping the supply of the logistics. So that's why the government is playing the role. But that's not the end. I mean, the government alone cannot do it, and it is the broad-based support from other supporting team. They are USAID MCHIP, they are American Academy of Pediatrics, the Hedal Foundation, Bangabandhu Sheikh Mujib Medical University, and the other professionals. And I will just tell in brief about the role of particularly American Academy of Pediatrics. They sent twice their expert for technical support. USAID and MCHIP, they actually provided us with the vision, designing of the whole training program. They also helped in procuring the logistics, that is bag and mask, mannequin, and also the penguin sucker. And the Bangabandhu Sheikh Mujib Medical University, where I work, we played a role that we actually gave training to the master trainers 68, 1,881 trainers, and we trained through them 23,557 trainers. So that all we work together.
Okay. Well, thank you. And let's go directly to Bertha, but my question to be modified a little. We understand why it's important. I think we understand what it is. It's probably the context in terms of why it's important is very similar in the LAC region, high neonatal mortality. This question I would have to focus the question a bit is, how does a regional approach to this intervention differ in terms of either the what or the who from a national approach?
And even though that...
Is the mic on?
Mic is not on.
No, the mic is there.
Okay.
No, you talk on the, you don't have to talk into that, you talk into the...
Here's your mic.
Yeah.
It's not working.
Still not working.
He's going to set something there.
Is mine working? Here you go, Bertha.
Okay, we can share.
Collaboration. Maternal newborn integration. Right?
Yeah, that's the diet. One of the things that is important for the scaling up from the Neonatal Alliance, that's a regional experience, is we wanted to address the equity issue. That has to do that equity has two aspects. First is that the health personnel didn't have access for the training. And second, the newborns didn't have the possibility of receiving the intervention. That is why for Latin America, the support we receive from MCHIP through the financial support of AID helped us to scale up at the regional level the HPB program. And I think that that's important because Latin America is a very diverse and complex region and has a lot of needs in the countries and between countries. No? The other thing is that HPB presented a simple methodology, and it allowed all the cadres to acquire the skills. One of the things that has been historically or traditionally in Latin America is that neonatal resuscitation has to do with very sophisticated issues. And HPB showed us that it was easy to roll down. It was an intervention that we have been doing it in the hospitals, but with very simple modifications, it was given in a more efficient way. What's the Neonatal Alliance? The Neonatal Alliance is a coalition of 17 members. No, we have UN organizations like UNICEF, PAHO, UNFPA, AID. We have professional associations, as the case of Bangladesh, that have helped us a lot to roll down this intervention. We have private sector as Mesoamerica with the IADB. We have Kangaroo Care that is, okay, mine's okay? Okay. No more collaboration.
I'll cut the cord.
Yes, and let the newborn live alone. So I think it's an interesting experience because we have provided strengthening policies. We have provided the possibility of training, master training workshops. And we have reached like 10,000 persons in the region with very modest funding, no? So I think it's a strategy that should be analyzed, should be thought about, and maybe it could be applied in other regions, no? One of the things of the Neonatal Alliance that is important is that we have different ways of scaling up the interventions, no? One is, for example, we have regional forums. Then we have an opportunistic approach. That is that when we find that there's a pediatric meeting, we go to the pediatric meeting and we give training with HPB. So the funds are shared with the Pediatric Association or the Obstetric Association also. Jeff accompanies us to the Congress of FLASOC. So we've been working with the maternal side also. And the other thing is that we have engaged in an experience that we are trying to learn about is the community of practice. Through internet to make these sessions to try to disseminate not only HPB but Kangaroo Care, essential newborn care, no, and it's been working. It's something that we have to work on.
Okay, well, it's impressive, especially when you mentioned it's been done with extremely modest resources. This is Jeff. So a different intervention. So what is it? Why do we do it? And who's been involved?
Yeah, thanks. I think everyone's aware that still, even though there's been a lot of progress, the #1 cause of maternal mortality remains postpartum hemorrhage. The paper released just last month looking at the distribution of cause of death shows that has come down quite a bit, but it remains the major cause of maternal death, hemorrhage. And so the intervention is really directly attacking that, but looking at provision of services wherever the woman is. So if she's in a facility, it's an intervention to prevent postpartum hemorrhage. If she's in the home, the same thing. It's the delivery of a uterotonic. So in a facility, it's focused on delivery of a uterotonic as part of active management of the 3rd stage of labor. But that's not possible at home. But those women are still deserving of an intervention that we can get to them, and that's through the use of misoprostol. So it's a comprehensive approach, regardless of where the woman delivers, because we want, really in the MCHIP program and going forward, we want to focus on equity. We want to ensure that every woman has access to a uterotonic. And with global consensus to address the problem, there is an agreement that use of a uterotonic at every birth is important. And we know how to do that. We know how to get a uterotonic to every woman to protect her from postpartum hemorrhage. So the people who were involved were at every level of the system. They were at the health provider level, they were at the household level, at the health system level, and at the global level. That was the role that MCHIP played, and that was the unique opportunity that we had as a global project to be able to look across regions and across countries, working with countries, but also bringing the experience together across countries and with global partners to really move this intervention forward.
Okay, so we're going to actually just have one additional question because we're going to save some time for the long-suffering audience. So the second question is, a lot of the things we've been talking about, sometimes they sound very simple, but we know they're not simple. These are public health interventions that can be quite complex, and the challenges of scale-up are real. So maybe we could reflect a little bit about the challenges that you've faced in scale-up, and then, you know, where are we at with these? What's really worked? How far along are we? And Jeff, I want to point that last part particularly to you. Where are we at in terms of actually achieving scale-up? And what are both the challenges and some of the successes suggest for the way forward? So you want to start?
Yeah. There are a few challenges when you scale up any kind of program. And in terms of HBB scale up, we found that on-site training monitoring was a problem. But as we saw that problem, we tried to solve it later on in the latter part of the intervention, that on-site training should be monitored very well. The other challenge is skill retention, and everyone will agree that once it is a skill-based program, as the time passes on, the skill retention goes down. So there has to be some refresher training, and in the beginning part of our intervention, we faced that challenge. Nowadays, we are trying to address that. The other is that many births are taking place at home which are not being attended by skilled birth attendants. So therefore, those babies, if they are not breathing at birth, they are missing the opportunity of helping babies breathe initiative. So that is a challenge. The last thing is that it's not being included in Bangladesh in the routine HIMIs. So therefore, if it is not being measured, there may be possibility of getting it down. So therefore, we are planning to actually include this in routine HMIS. So these are the challenges that we found with HBB in Bangladesh.
Okay, thank you. Bertha.
In the case of Latin America, for us, HBB is part of a learning process. And I think that is how we have approached it. We want to go further than training and policies, because policies and training is the easy part. As a doctor from Bangladesh has just said, supervision, supportive supervision is essential, and then how we monitor the impact of this intervention. No? One of the things and challenges we have is, well, limited funding. Is for nobody is going to discuss. All the countries have the difficulties. And the other is the resistance we have with the professional associations, especially with the neonatologists. How we have tackled this problem is we have invited the neonatologists, we have invited them to the training with other cadres, auxiliary nurses, community health workers, and we have made them share their experience and made them share also how the other cadres are learning also, no? And that has helped us a lot. But one of the things we need to express is we cannot speak of scale up, and I think most of the audience and the persons that have been here in the panels, is that scaling up has to do with equity, how we close the gap between those who receive the intervention and those who cannot receive it, how we can scale up with maintaining the quality of the intervention. Because sometimes we want to scale it up, but we don't think about what is the consequences of a training that has problems in the skills and maintaining the skills, as you just said, no? And the other thing is that how we can sustain it, and that is governments and partners. Partners is a small word, but it implies a lot of responsibilities. So we need to work in collaboration with other partners, so when we go, we leave the country, we have the government and other partners that will do the advocacy for the scaling up, the continuous of the scaling up, no?
Okay. Jeff, last one.
Sure. You know, John, sometimes I think we're victims of our own complexities. I think sometimes we can make things more complicated than they have to be. And so what we tried to do was simplify this. It's a uterotonic for every woman at every birth, regardless of where she is. Mm-hmm. And I think simplifying it helped us move it forward and move it further out. But there were challenges. I think there's still not global consensus about the use of misoprostol at home birth, the advanced distribution of misoprostol. And so we needed to learn as we went forward and work with countries who were willing to step out on a limb with us. They recognized the need of the people, but they were fighting against some global concern. And so in country after country, we went in and we worked in partnership with the Ministry of Health to design a program that would allay their concerns and fit their context. So for example, in South Sudan, we designed a program that was addressing the needs of that health system, which was a health system that had a lot of community-based services because the health services were limited. And so in that system, we were able to get 94% coverage of use of a uterotonic at births. And especially important, for the majority of women who deliver at home, we achieved 99% coverage of use of a uterotonic, misoprostol, at birth. But then in Liberia, they were a little bit more resistant or a little bit more cautious in terms of giving the misoprostol to women, to the traditional birth attendants for distribution. And so they designed a program that was more cautious, distributing through antenatal care. And unfortunately, they achieved only 54% coverage. And among those women who delivered at home, only 24% coverage. But what did they do? The most important thing is they learned from that process. They learned what they could and couldn't achieve, and they changed their policies. They decided that this wouldn't work for them with the formula that they had put forward. And so they identified a better approach using the community health system. So we worked with countries to identify local context, design programs that met their needs, and learn from those programs going forward so we could achieve that simple message of a uterotonic for every woman at every birth, regardless of where she delivers.
And Jeff, on the question of where are we now?
I think we're gathering this information. Last week, we published the results of the study from Liberia. Next week, we'll publish the study from South Sudan. And so I think as the global tide of evidence is coming forward, I expect that there's going to be a shift in the policy at the global level from WHO. But regardless of that, countries know what they need. Countries know how they want to serve their populations. And so in many countries, in Bangladesh, in Nepal, they're moving forward and making this program work at scale at the country level in order to address what they know to be the problems. So step by step, we'll go forward and some people will come along behind.
Okay. All right. So with that, so the question I've got first, I want to have a time check. This was the scheduled time of the closing remarks. Do we have 10, how many minutes can we take for questions? Okay, you've got a little bit of flexibility. We'll take about 5 to 10 minutes of questions. Great, so we'll start from the floor now. So now this is, it's open, but I ask that you really keep your question confined to about a minute if you can.
A second.
Okay.
Any question?
We need a roving mic. We're going to lose precious seconds this way.
No, I've lost 50 seconds.
We get some kind of time built in at the end for this, don't we?
Hello.
Okay.
Okay. Okay, my question is, working in the Latin America region, which I'm most familiar with, one of the the contextual factors that we rely upon a lot in introducing new best practices, techniques, and so on, is that countries, there's a kind of peer pressure among countries, and we have a number of alliances that that foster that and facilitate exchange of ideas, but also a sort of a sense that our neighbors are doing this and doing it better, and so we need to step up. I wonder if that's a dynamic that that you see in other parts of the world. And I guess I would wonder, Berta, would you agree with me that that's an important component of how we advance in LAC?
So while we start with Berta responding to the second part, do you agree? And then potentially, Mohammed, if you want to talk about, does the same kind of network apply in other regions? So.
At the end of the story, what matters is what the countries do. So the Neonatal Alliance only at regional level facilitates and strengthens the national alliances. So that's how we have worked with Dominican Republic, with Colombia, and it works, no? Because you share with other countries, and the countries say, okay, let's try. Because the important thing is how we incorporate the new intervention. So. Yes, it works.
Okay. And then, Mohammed, do the Asian countries compete with each other? Is that important?
No, we very recently developed a forum known as South Asian Federation of Pediatrics, SAPA, and we have common problems, and we actually share our experience between each other. So I think this kind of alliance is very good way to actually take the agenda forward in a region where you have a common problem.
Okay.
John, just briefly, if I may, one of the things that I think were very important from a global leadership perspective that MCHIP did was to have regional technical consultations. We had a very important one in Addis Ababa. We had another one in Dhaka. And at those meetings, countries were able to come together and talk to each other. They learned from what their colleagues were doing. They learned that others were willing to take risks. Others were implementing programs. And I do think that kind of peer pressure, that sense of this is what everybody else is doing, I see this as important for my country. We were able to foster that through some of those global meetings.
Okay.
And one small thing, what we are thinking about is how to do a workshop in which all the countries can speak about the 10 things you never should do. Because we think that we learn a lot of the things we have done that are not so well, no? And that means that we need an environment of a lot of trust and confidence between countries, no? That's workshop in which, okay, I did it very wrong, and let's learn about it, no?
Oh, I love that response, Berta, because one of my theme songs is please tell us over and over again what doesn't work, because we've got to learn that. Okay. Other questions? We got, where? Okay, here.
First of all, thank you very much for your productive discussion indeed in terms of scaling gap. From our perspective, indeed, scaling up a new innovative approach across the country will have 3 consequences. First is cost implication. Second, has been told by one of the panelists, policy implication. And the third, integration to the current existing system. How you are coming, let's say, those are many challenges. They are very important challenges indeed. While you're coming up with an innovative approach, which has not already been indicated and included in our policy, how you are going to replicate that without changing the policy. And changing the policy is not that easy task. So how you are overcoming those challenges?
Yeah.
So, want to pick that up?
First is policy implication, then your financial implication. So every country knows that what is their problem. In Bangladesh, we know that we have a problem with newborn with birth asphyxia infection and preterm low birth weight. And naturally, no one wants in this room a baby who is born, is not breathing, should not be given any assisted ventilation or support. So therefore, the government has understood it very well, and government has included this in the policy. That's not a problem. The other thing is about the financial thing. It is the government, and at the moment, of course, the development partners are supporting it, but government has included it in its policy, and in the annual operation plan is there. So I think when it is a question of saving newborn lives, that is, and it doesn't involve that much of money, particularly in terms of HBB I'm talking about. So that should be there on board.
Okay. Bertha, Jeff?
Well, you know that in Latin America, we've been working with WHO algorithms for neonatal resuscitation. And sometimes to introduce a new intervention is easier than to explain that you have the intervention, but this is better. No, so we had this challenge, and we reached consensus at policy level first, at the regional level with PAHO, and then we rolled it down to the countries, and we have countries like Colombia and Bolivia that have already incorporated the HBB algorithm in the IMCI. So it's difficult, but we can manage to do it. Thank you.
Mm-hmm. Just John, just to add on to Bertha, in Bangladesh, the government, as it has been included in the policy, this has been institutionalized, which means that this HBB protocol is being included in the pre-service education, in undergrad medical education, in the curricula of the nurses, midwives, SBAs, and also this has been included in the training manual of the NGO workers. So once it is being institutionalized, I think it's very easy now. And the persons who will be going through the process, once they go to the field, I mean, they are in the workplace, they are providing this service. So I think that's the way, this is not a problem that you can run the show in the country.
And Jeff, anything you want to add to your earlier comment about the alignment of policy and how to influence it?
Sure. I think sometimes in order to change policy, we need evidence. And that's either programmatic evidence or clinical evidence. And we can get some of that from the global level, but we need to get some of that at the local level. And so I think in order to change policy, we need to look at how things are going to work in that context. And so a step-by-step approach, hand in hand with the government, to identify the questions that are of concern to the government, and then to tackle those questions one by one. That's the way to make policy changes, because then the policy, the change in the policy is realistic based on the context.
Okay. I think we're going to have to wrap up. So let's thank this panel. I'm going to also exit and make some space for Ariel Pablos-Mendez, our Assistant Administrator for Global Health. But I also want to reflect on a couple of things one or two things that tie the 2 days together. And I want to tell you about 3 things that stuck with me in terms of what ministers of health have said over the last couple of days, and they're just short things. So one was the Minister of Health from India saying the first step is to believe that it can be done. So I think that when we have a technical evidence base and we have a programmatic evidence base, that we think this is something that's actually going to have an impact on what we're all trying to achieve, we have to believe that it can be done, and that's the first step. The second, and this relates to some of the things we've just been talking about here, Minister of Health from DR Congo, talking about the importance of government leadership and country ownership. And I think that he's certainly been somebody who's tried to drive his process forward at country and have exhibited strong country leadership. The last doesn't come from a minister, and I'm not just saying this because you're in the room, Ariel, but because it stuck with me when you said it this morning. It was essentially the momentum can be lost, and the way to sustain momentum is by getting, measuring, and reporting results. So I do think that as we try to go to scale, we've got to make sure we're measuring the things we need to measure, and we're actually getting the kind of results that are going to help us sustain the interest we have in ending preventable maternal and child mortality. So I'm going to get off the stage now. Welcome Dr. Ariel Pablos-Mendez for his closing remarks for this event.
A learning opportunity, but also a celebration. And I think that much has been accomplished, and it deserves that celebration, especially when we can share with all of you, our distinguished guests and ministers, our colleagues, our staff, our family. I always think of our implementing partners as an extended family in USAID. That's the way in which it all works out. It's been a fantastic 2 days for me personally and for our teams. We often talk about flagship awards, flagship platforms, and of course, MCHIP has been a flagship of flagships in a way. And we had last week just launched a book on the 50 years of work in global health of USAID. And of course, this recent history has accelerated so much, and MCHIP has been the power behind much of the recent acceleration in the annual reduction of rate of reduction in child and maternal mortality. And just in the last 20 years, as you have probably heard me say before, 100 million children's lives saved. That's an incredible, incredible number. And it's that success, which MCHIP has been a central part of, that allowed us here with John, Troy, and others, to imagine the idea that we can end preventable child and maternal death. And we can now see it. It is happening. We are 80% of the way there, and MCHIP helped us get to this point, and also to make it visible, and also to bring us all together to see that vision, both at the Child Survival Call to Action 2 years ago, and on acting on the call just yesterday. I want to thank MCHIP for their support, and particularly Charlene Reynolds, who really make sure everything worked out to make these 2 days a success. So much to celebrate, much to learn. I don't mean to rehash a lot of things that you have been going over today. I was asking my staff, what did you learn after all these conversations? Because we know a lot already in this group. But I think, and we heard it in the last panel, keep it simple and make it happen in the countries. And I think that nothing is truly simple, or it shouldn't be simpler than it has to be, but indeed, by making it work, you require that degree of strategic alignment with the countries. Again, MCHIP has been a great example of that. I'm sure you share many other lessons. The country lessons in particular are important in these opportunities. We do evaluations sometimes earlier because we also want to learn enough for the successor platforms and award to be designed according to the learning. And so our teams do that, and I'm sure we have brought much of that already into our new maternal and child survival program, which we announced to the broader community yesterday. And I want to thank again Koki for your leadership before and now. And of course, our own staff, Nahed and John, and everybody who you know well, because it's like a family, how all this operates in making, it's just so much work every day in, day out, so many people to thank. But I believe that this program will bring continuity and leverage the history of success, the success we just had been reporting all to the world, to our Congress, to the American people. I couldn't be here also at the opening because we moved immediately to a discussion of an idea, just an idea. I believe in many ideas, as you probably know, and the power of ideas. And one idea has been one of bringing together a global financing facility to see us through the next 2 decades of work in this area, to bring new resources, visibility. And in a way, about 3 years ago, Tori Godal from Norway had the idea, should we also have a global fund for maternal and child health? And that idea has been in many conversations. But 3 years ago, the financial crisis was fresh. The Global Fund for AIDS, TB, Malaria, the Global Fund, was struggling, and nobody wanted to create new institutions. So timing wasn't right. There was no appetite for it. And yet, everything is timing. And now, because of the explosion of interest and support for reproductive, maternal, and neonatal child health in these recent years, there was also an explosion of all sort of mechanisms. Many of the Europeans who do not have mechanisms like ours, trust funds here, trust funds there, many of those things out there, and also replications, duplications, as John knows very well, a steering committee here, another meeting there, the same people meeting again and again. And the country is bombarded with all sort of angles and initiatives and so on. So we want to make sure that in addition to the flagship programs we have already on the ground, we can bring together some of the global community to create greater visibility. And so this idea that we began to discuss following the World Health Assembly was the subject of a meeting today with many of the agencies who have equities in this space. Some ministers join us in the conversation to discuss all the possibilities. And it's clear that there's a great consensus in the diagnosis that we are at an incredible time in global health, that indeed the results are dramatic, that we have a vision to go forward, that there's a gap in the resources nonetheless to bend the curve as we want. And at the same time, we are in a different world today than where we were in the year 2000, when there was an implosion of hope in Africa, and we had debt relief as the most important thing, increasing ODA. Now, Africa is the fastest growing region in the world. And many of the countries we used to work in, we have graduated because success in international development, success in their leadership capability and program results means that we are in a different time than we were in the year 2000, when the other global fund was established to give grant money. We are now in a different time. The economic transition means many countries are moving across the $1,000 income per capita threshold, and without health expenditure also growing. How do we handle this? How do we engage with countries? How do we ensure that new financing mechanisms exist that allow us to move from grants to loans, that allow us to leverage the World Bank's IDA pool of resources to do even more, that brings consolidation to all of these smaller splinter trust funds, that creates greater visibility at the global level as we enter the post-2015 agenda. So you have to imagine it was a rich conversation. And it worked quite well, because you can imagine also there are many interest perspectives, but our teams in the Office of Health Systems did a good job, and working with the bank and the Norwegians, it ended up being a great, great conversation. We are following now with the President of the World Bank, with the UN MDG Special Envoy, with others, to see us into the possibility. And it's not yet done, but I wanted you all to be aware of the conversation. And we will probably engage you because of your expertise already in this space down the road as well. So we were doing that. And I also want to note, I heard John again, the point about the importance of evidence, data, and results. And we have done a decent job in this space. We certainly need to do better. And not only in our own management enterprise, but more importantly in the capacity of countries to have all sort of sources of data for their own routine management, for their own stewardship. And we are going to be convening with WHO and the World Bank a measurement summit early next year to bring, and I'm saying this because I'm getting a sense that we will lean on you as well because of what you have already been doing in this space going forward. So just a warning, there's plenty of big ideas right now on the table as we enter the final stretch of the post-2015 agenda, where we now are prepared because we have targets for maternal, newborn child mortality, and for also access to modern contraceptives. So we are in good shape in that conversation. You are all part of that conversation. And again, my hat off to MCHIP and welcoming to now the Maternal Child Survival Program, and thanking you all for those who have traveled from afar, safe travels, and for my team, for our team at USAID. And as I said, I'm an adopted child because it's a big family who has been around for a long time. I want to honor our staff too. All of this success has taken years to build, decades to build. And the excellence of our staff, both in the management of the enterprise, and it's complex, as you all know well, but also the technical excellence, the leadership of our group. I also want to end with both my thank you to all of you and my recognition to our staff at USAID. Thank you very much.
Involved with MCHIP from AID to please stand up, just so we can see who
Good
you
idea.
are. Let's give them a hand. And now I'd like to ask the staff from MCHIP to please stand up, so you can see all of our staff together. And finally, Charlene was mentioned, so Charlene's not allowed to sit down yet, and I'd like Jim to remain standing, because Jim Ricca was kind of the brains behind the operation today, and I wanted to make sure that we gave him some special recognition.
Thank you.
As Jim had the very incredible task of distilling and identifying the key priorities that we presented here today. So I don't think he slept in the last couple of weeks, but I wanted to make sure that we made a special recognition of Jim's contributions to pulling together today as well.
Thanks.
Yeah, go ahead.
Well, thank you to everybody. First, thank you very much to the communications team at MCHIP. Did a fantastic, amazing job pulling everything together, both for yesterday and today. I really think they need a round of applause. Can you all stand up? And thanks so much. There would be nothing to learn about and present if there had not been fantastic programs, and there were. So thank you very much to the Ministries of Health, to all the MCHIP staff and countries, and to the presenters who came here and worked so hard on your presentations. Thank you. Thank you again.
Two quick things. I think somebody mentioned this morning, you saw in your folder, there's a nice kind of card. It looks like a credit card. This has all of the documents on it. This is actually a USB drive, so don't lose this. This has lots of important information on it that you can use in the future. And the second very important announcement is Ariel mentioned that this is a celebration. So we'd like to continue the celebration and invite you all upstairs for a drink and some time to spend together at a reception in the pavilion room upstairs. So please join us.